Thank you. I take solace in the fact that you have to say something 7 to 50 times before people begin to have it sink in, because what I have to say has already been said. I'm going to do a couple of things. One of them is filter what we're talking about here through the lens of primary care, not because I think primary care is important, which I do, but because primary care is a sort of a bellwether system of care for dealing with the kinds of problems we're here to talk about today. And I think the principles of successful primary care apply to our healthcare system at its worst and at its most embattled up and down the spectrum. So these principles should be somewhat generalized. I'm also going to talk a little bit more about the how rather than the whether or the why. I'm going to get close to the ground and try to say something about how primary care at its best looks and works to see if we can pull some lessons from that. We've already, I think, done enough on what is high need. This is a beautiful and interesting and curious conversation from my perspective. We did this PrimeMD validation study, PrimeMD PHQ validation study about 10 years ago. And one of the things that we learned in the process of close inquiry of a whole bunch of patients, a couple thousand primary care patients selected for the purpose of creating and validating some instruments was the following. We learned the following. There's a linear relationship between the number of symptoms that people have that people will admit to, whether those are psychological or biomedical symptoms, doesn't matter. The one runs with the other. The more of one, the more with the other. There's a linear relationship between the number of symptoms and the cost of care and the frequency of visits and the quality of care and the satisfaction of care and the frustration of taking care of these patients on the part of providers and overall health, including functional status. So I really appreciate the beautiful setup that Melinda did, and I'm glad, may you stay alive forever, because so long as Melinda and the people like Melinda are on the job trying to figure out how the circles of the Venn diagram overlap, I don't have to think about that very much, and I won't. I think that we've got, in the world of primary care, we can stratify patients into need a lot of stuff, don't need so much stuff, can basically be managed just with me. And the people in that category can be described by all of these criteria that we're working our way through, which are important, which matter, which have everything to do with how we find and deploy resources. But the people in those circles change all the time. One year, it's one set of people, another year, it's another. It also depends clinic by clinic and clinician by clinician, which of those is most salient for you because of your skills, your talents, the other resources you've got to work with, the environment in which you're operating. So I'm much less concerned about our parsed definitions of who's high need and much more concerned about something different, and that is how we actually approach them. Because there's a problem of we fall into well, let me say it differently. We've got a fetish in this country of specializing and hyper-specializing and hyper-subspecializing. We split off so that we've got extremely deep slices of expertise to manage particular problems. In the world of primary care, the patients who, I did a lot of work early on before I knew any better with somatizing patients, patients with unexplained symptoms. These are patients who, if you, depending on where you set your red line, 100% of them have conditions, comorbid conditions with other things, depression, other anxiety disorders, a lot of medical disorders and chronic illnesses, bad functional impairment. So if you look at those patients, depending on how you set your lens, you might be directing an intervention against depression. And that will be effective for a subset of those patients. You might be directing an intervention against somatization. Those patients have diabetes, they have coronary artery disease, they have chronic lung disease. If you go after this disease by disease, you're doomed to failure. And so one of the things that dealing with patients with complex multiple problems will teach you is whole person care is the only way to go. Remember that thing about having to hear it 7 times? Whole person care is the only orientation that makes any sense. There's this definition of primary care that was developed in 1994 as part of an Institute of Medicine study on primary care, which is still useful. And it's worth revisiting for just a moment today. This is a definition that describes a number of functions. And there are a couple of these I would like to draw a line under. One of them is integrated care. One of them is addressing a large majority of personal health care needs. Most or all of the problems that a person has can and should be addressed in primary care in an integrated fashion. One of them is sustained partnership. That's over time, longitudinality or continuity. Different concepts which for our purposes can be thought of as the same today. In the context of family and community. Now, the reason that this definition took the shape that it did is because each of the features, each of the descriptors of primary care here have known value. If primary care is of such a sort as described here, each of those features confers value. It actually causes the care rendered under that condition of primary care to be less expensive or more effective or more equitable or more enjoyable or rewarding. And there's a reference at the end of this that'll get you started on that literature if you care. So that's a long-standing notion of why primary care matters. Now, we used to think that primary care was defined by the problems that we took care of until we realized that the kind of care that you render is as important as the kinds of problems that you're addressing. How we practice matters. The chronic disease model was our first kind of opening to that. Thank you, Ed Wagner. How we practice, which in this case, as the rise of chronic diseases appeared, we found ourselves more and more dealing with chronic diseases in a model of care that didn't fit that. So chronic disease models gave us a set of tools that have been very valuable in terms of coordination, care managers, in terms of registries and outcomes-based care and so forth. But chronic diseases are also a disease at a time. And when the patient-centered medical home concept appeared, it brought us back again to the notion of whole person care and the recognition that care is personal and it's local and it's individualized and it's co-created and it changes all the time according to the waxing and waning of severity of problems. Keep this in mind, that it's local and that it changes all the time. As we begin to think about the problem of comprehensiveness and how primary care is getting parsed and fragmented and truncated, the notion of reintegrating behavioral health into primary care acquired a new salience. This is the biggest single bite you can take toward comprehensiveness. Somewhere around 2/3 of the patients in primary care have either functional impairment as a result of psychosocial problems or an outright mental diagnosis. If those aren't dealt with, it's impossible to do whole person care. The notion of behavioral health is really important. Equally important is the notion of incorporating into the community. When primary care becomes community grounded and community based and becomes the business of the community, a couple of interesting things happen. One of them is a new workforce appears. There's a new workforce that is invisible if you're not thinking about the context of family and community, that becomes apparent, that has needs and that has value. It's also possible to think seriously, sort of for the first time, about prevention. And it's also possible to think about population health when you are dealing with community. The notion of patient-centeredness is, I think, is actually going to be the hardest and most radical transformation of primary care for us to accomplish. This is the end game. You know, we think about patient-centeredness as though that means inviting the patients to be on the primary care team. It is the patient's team. I'm on the team if I behave well and I have something to offer. The patient is the owner. And what they need from me is sometimes information and sometimes access to resources, and a lot of times things that I'm not used to or think that I'm good for. But I'm going to have to get used to that if I'm serious about patient-centered care. And I am serious about that because I think that's when care becomes much less expensive and much more valuable. So another interesting phenomenon happens with serious patient-centered care, which is that the notion of providers and consumers kind of disappears. Provide, give till I burn out. Consume, take. I need, I want. There are times, of course, when that's appropriate and that makes sense. But the notion of a healthy kind of partnership, particularly with the patient as the director or as at the center of that, changes the notion of provider and consumer into something that's much more of a partnership and much more democratic. Oops. There we go. There's a lot of detail here that I'm not going to go into because I've only got a few minutes, but I want to underline the notion of successful clinics and successful primary care settings on the basis of, well, we heard some marvelous results from Alan, and there are a number of other studies. A couple of these you'll find in your references on the last slide. One of which is a beautiful, I guess you'd call it an Integration Academy, ARC-sponsored guidebook on what successful primary care practices that do the kind of primary care that actually confers value look like. It is an absolutely beautiful book which describes direct observations of about eight practices on the ground for a couple of years. There's another project that's called the ACT project, which ran for 5 years, directly observing practices as they try to become comprehensive and try to become high-performing, comprehensive, integrated practices that gave us information as a result of direct observation that we didn't have before and that we haven't been sufficiently sensitive to. A lot of the details of this slide talk about the parameters of the notions within those practices on the ground. I'm not going to do that. But what I do want to say is that these practices are all, among a number of other things, are all characterized by a very high level of flexibility and adaptability. And success depends almost directly on a certain kind of leadership. This is important. This is somewhat invisible up to this point, but I want to talk about complex adaptive leadership, and then I'll be done. I consider the kind of leadership that occurs in the context of successful practices that can deal with high risk, high cost, difficult patients, the single most important element. And it occurs at 3 levels. One of them is at an administrative level. That's a fairly high level. And this is the level of CEOs, clinic managers, hospital directors, medical directors, and so forth. Look at those characteristics of success there. Building and protecting the vision, acquiring resources, managing crises, getting out of the way. That getting out of the way is really important here. You'll notice the next is adaptive. That's at the ground. The clinics that are most successful are able to respond. Things are continuously coming out of left field. There's a continuous problem-solving proposition going on, and it takes a couple of years for clinicians and staff to actually learn how to solve problems adaptively because we're not used to it. It requires being creative, staying flexible, and continuously solving problems that you don't have the resources to solve. It also involves taking risks and failing. There's an enabling layer which connects the two, which keeps the administrative leaders out of the way, which makes sure that there's enough structure and yet enough flexibility to deal with the problems at hand, and which makes it possible to generalize those lessons that become principles and not local solutions. There's a set of references, and that's all for me.